Okay, assalamu alaikum, good afternoon. Thank you very much for attending this session. So we're going to talk about the traditional way versus the new molecular way of diagnosing pneumonia. What's the clinical outcome when you use either, and how the new approach affects the stewardship, the infection control, and management of MDRO and XDRO pathogens. So this is the ICU respiratory pathogens 4 years ago in Sahha facility. And I want you to pay attention to the Pseudomonas susceptibility to meropenem. It's shocking. Compared to piperacillin tazobactam, piperacillin tazobactam is doing a better job compared to meropenem. So it's not always broader coverage means better coverage. And if you check what was the cause of ICU infection, when it comes respiratory tract infection in the ICU globally, it is always the big three: Pseudomonas, Klebsiella pneumoniae, and E. coli. And locally in the Gulf area, and I have the privilege to participate in this study, we add to that Acinetobacter beside the Pseudomonas, Klebsiella, and E. coli as causing infection in the intensive care unit. But the problem is not only those pathogens. Those pathogens became more resistant, and we need to use more potent broad-spectrum antibiotic. Let's agree upon the definition of hospital-acquired pneumonia, ventilator-associated pneumonia. So let's start with the basics. Let's take myself an example. If I get sick and I have cough, fever, I go to the ED and they diagnose me with pneumonia. This is CAP, community-acquired pneumonia, as easy as this. But let's say I was admitted for, let's say, a back pain. And after my admission, 2 days and above, 48 hours and above, I developed pneumonia. I did not come with pneumonia. This has happened 2 days after admission. This is when we call it hospital-acquired pneumonia. And in most of the cases, it's linked to the infection control. Why someone who doesn't have pneumonia develop pneumonia inside the hospital? Unless our staff, the healthcare workers, whether doctors, nurses, whoever, are not doing good and proper hand hygiene and infection control. But the bottom line, if you develop hospital-acquired pneumonia, either you stay stable without intubation, or you develop worsening saturation and you end up intubated. But the pneumonia happened before the intubation, so this is not a VAB, ventilator-associated pneumonia. Someone was admitted to the ICU, intubated, and after 2 to 3 days, 48 to 72 hours, found to have pneumonia, lung infiltrates in the lungs, sputum is positive. All the parameters suggest pneumonia. This is VAB, ventilator-associated pneumonia. Again, someone was in the floor with pneumonia, got worse, and admitted to the ICU, intubated. This is still not VAB. This is hospital-acquired pneumonia, ventilated. This is the same story or the trip of a patient with pneumonia. Either you are having HAP, hospital-acquired pneumonia, either you stay without ventilation or ventilated. Someone without pneumonia got ventilated and developed pneumonia after 48 hours, 48 to 72 hours. This is VAP, ventilator-associated pneumonia. Clear? So again, what difference does it make if you are a newcomer, first long-standing resident of a hospital, in the ICU or in the floor? The more you stay, the more likely that you will acquire resistant bacteria. So someone who is having hospital-acquired pneumonia, who has been in the hospital more than 4 days, there's a larger chance or bigger chance to have resistant bacteria. Someone within 4 days of admission, less likely to have resistant bacteria. And the explanation is easy. Every day you stay in the hospital, you increase your chances of catching bacteria. and resistant bacteria. Hand hygiene, exposure, or even having an antibiotic on board, but bacteria develops resistance. 2 days, more chances, 3 days, 4 days. So the more you stay, the higher the chances to acquire resistant bacteria. Beyond 4 days, big chance of having resistant bacteria. What do you call this? If the lab doesn't tell you this is ESBL and this is E. coli that's resistant to cefotaxime, or if they tell you it's resistant to ceftriaxone, they are exchangeable, the same. This is ESBL, extended spectrum beta-lactamase. If the lab doesn't tell you this is ESBL, give you the gene responsible for the resistance, then, the mechanism responsible for the resistance, look at cefotaxime or ceftriaxone. You have an E. coli or Klebsiella that's resistant to cefotaxime or ceftriaxone, most likely, I'm not saying always, but most likely this is ESBL. Okay, what do you call this? This is a Klebsiella resistant to meropenem. What is this? CRE. As easy as this, carbapenem resistant Enterobacterales. Okay, so what about this one? Staph aureus, but it's oxacillin resistant. But there's no methicillin here. Where's methicillin? We stopped using it a long time ago. Why? Kidney problem, nephritis. It used to have bad kidney or nephrotoxic effect. Then we stopped using it and we start using oxacillin. And now in the labs, they check oxacillin to tell this is MRSA, methicillin resistant versus MSSA, methicillin sensitive Staph aureus. So this is MRSA, methicillin-resistant Staph aureus. What about, this is a nice IDSA updated guidelines from the 2024. And I want you to look at the left side, the CRE, the carbapenem-resistant Enterobacterales. It comes with 3 groups or 3 flavors. Whether this is KBC, easy to treat, multiple medications, but unfortunately, we have less than 1%. You rarely see it. Almost doesn't exist. It's still in Europe, North America, and some other areas, but not in this region. What about OXA48, another flavor of the CRE? Around 40 to 50%, and it's susceptible to ceftazidime avibactam alone, the drug of choice, and also to the new medication cefiderocol. MBL, metallobeta-lactamase. I put it in red because it's very resistant and few medications can work. Whether it's a combination of ceftazidime, avibactam, and aztreonam given together, or cefiderocol. Difficult to treat, really difficult to treat. So let's go through this case. This is a 48 years old male patient, smoker, came to the ED with pneumonia. He had cough, fever, greenish sputum, shortness of breath, X-ray, as you can see, left lower lobe obesity or opacification. Started on ceftriaxone and azithromycin, which makes sense because the patient has CAP. This is the normal or by the guidelines treatment. Then this patient had blood cultures and sputum culture that are negative, no growth. Became worse, went to the ICU because of desaturation, intubated, upgraded his antibiotics to piperacillin tazobactam. Then they did what we call the molecular testing of the sputum, the pneumonia panel. And they found E. coli, and it says CTXM positive. When you see CTXM, it's equivalent to ESBL. This is the most common mechanism it's not the only one, but the most common one to this gene codes for a resistance mechanism. If it says, let's say, Staph aureus, and it's MIC-A or C positive, MRSA. If it says, let's say, E. coli or Klebsiella, and it's KBC, OXA, VEM, IMB, or NDM, New Delhi. This is CRE. So this is what we call the genotypic resistance pattern, okay? So this patient was shifted from piperacillin tazobactam to meropenem, which is the drug of choice, or the carbapenems are the drug of choice for CRE, for ESPL, and he improved extubated. So we have the classical way to diagnose pneumonia, whether it's a history, physical exam, doing chest X-ray, sputum for gram stain and culture. But is this methodology or approach very sensitive? Unfortunately, no. Poor accuracy to diagnose pneumonia, let alone to diagnose the causing pathogen. So, okay, if I have a positive X-ray, what causing that? Do you have always a positive culture? No. Why? Multiple poor samples, patient cannot give good enough sample, previous antibiotic intake, a lot of reasons. And we need to get better outcome, two things. We need the appropriate antibiotic to be given in the right time and for the right bacteria. So all studies, including this study, the meta-analysis, as you can see, showed that if you give the right antibiotic in the right time, as soon as possible, and if the patient is septic, and you know, when you have sepsis, we call it the golden hour, within 1 hour, as soon as possible, the outcome is better based on this meta-analysis of more than 100 studies. On the other hand, if you don't give the right antibiotic on the right time, the outcome is bad when it comes to morbidity, so failure of treatment. The same thing for this study, same message. So let's talk about traditional way of diagnosing pneumonia versus the molecular testing, the new approach. If you have a guy with pneumonia, what you're going to do is sputum sample, correct? You start antibiotic, empirical antibiotic. You don't know what's the pathogen, but you do your best to guess based on your local antibiogram, what do you think this patient is maybe colonized with, anyhow, and you wait for the sputum gram stain and culture. Then you grew something and you wait for the susceptibility. This takes around 3 to 4 days. By day 4, you have the targeted antibiotic treatment or therapy. You know exactly what you're treating. Molecular testing gives you this within a couple of hours, 1 hour. What happens between this day on day 1 and day 4? Patient might get worse. Patient might get into sepsis or sepsis cascade. And you know the prognosis is bad, and sometimes it's difficult to halt and stop the sepsis cascade. So again, we know that it is faster for diagnosis. How do you order? For example, if you have someone with pneumonia, you want to know what he has, go to PCR. This is Saha system, by the way. Write PCR, then pick pneumonia panel here, and it will give you the option, sputum sample, for example. What about the results? Fast, within 1 hour. You can give it to, if the sample gets to the lab, it is 1 hour from machine to results. It can detect more than 15 bacteria, 9 viruses, and gives you the genes responsible for resistance. What is good about it, it gives you also the atypical pathogens. Let's say Legionella, Mycoplasma. Those are really difficult to culture. No matter what you try to culture the sputum, you can't get results for Legionella. You used to rely on urine testing, antigen. You can't culture Mycoplasma, while PCR can do. And it gives you the genes responsible, as I mentioned, for resistance. So if it gives you, let's say, VIM, IMP, or NDM, we know this CRE, KPC, also CRE, OXA48 CRE, or it tells you, for example, this is CTX, we know this is ESPL. Okay? Let's go through this case. This is a 78-year-old female, diabetic hypertensive with coronary artery disease and chronic renal insufficiency, admitted with pneumonia and severe sepsis. Sputum and blood cultures requested, pneumonia panel done, and within a couple of hours we have the results. E. coli and its NDM. How do you treat this patient? Colistin, amikacin, ceftazimab-bactam, and aztreonam, or cefiderocol. And we know the answer is either one. Either you give solo cefiderocol, ceftazimab-bactam, plus aztreonam. So culture came back, and it's resistant as we expected to ceftazidime avibactam because this is NDM. And we know it's resistant, correct? So, but it's susceptible to colistin and amikacin. Should we use it? The guidelines said, no, don't use it. Why is that? High failure rate, high toxicity. Okay, so again, we give both ceftazidime avibactam plus aztreonam together same time in extended infusion over 3 hours together, or solo treatment with the new agent cefiderocol. This case also, I think I have 3 slides left. So this is an 88 years old male, diabetic hypertensive CHF and CVA, who's a resident of long-term facility, comes with pneumonia, fever, cough with yellowish sputum. Now the sputum culture 1 month ago grew Pseudomonas and ESPL, E. coli. Chest X-ray, the new chest X-ray showing, as you can see, bilateral congestion, but of course, you cannot rule out pneumonia in such an X-ray. A patient was started on meropenem, but no improvement. Patient has worsening saturation and sputum and the blood cultures are negative this time, no growth. And we did molecular testing and it showed the following. It shows Klebsiella, it shows Pseudomonas, and when it comes to the genes responsible for the resistance, it is NDM and CTX. So if it is CTX, it means ESPL positive, correct? Meropenem should work. What about the NDM? Meropenem cannot work. It's CRE, it's carbapenem resistant. Okay, what about Pseudomonas? Look, pay attention also to the following, the numbers beside detected. 10 to the 7th there, and for the Pseudomonas, it's 10 to the 3rd, correct? It tells you how many copies can the machine detect. Why is this important? Anything below 5 likely to be colonization, not pathogenic. 5 and above, 10 to the 5th, 6th, 7th, 8th, 9th, significant, and you have to consider it as pathogenic. Because molecular testing can give you multiple positive results in one sputum sample. Should I go crazy and treat all of them? The answer is no. Only the significant one with high power, like 10 to the power 5th or more. So again, the machine detects any bacteria 10 to the power 3 and more, and consider it as pathogenic and must be treated when it's 10 to the 5th and more. Usually we give sample, okay, this is what I told you. Usually we get samples either like good deep sputum sample, bronchial aspiration, brush, any good sample, deep sample would be very good, have a good positive predictive value and negative predictive value. It's very specific and very sensitive. It can tell you this patient has or hasn't the infection. Is it affected by antibiotics? No. You know, if I give you an antibiotic and you don't get better and you go to the hospital, sometimes, we know the culture is negative. We call it partially treated, let's say meningitis, pneumonia, any kind of infection. But molecular testing, unlikely to be affected. This is the last case, 47 years old, patient, liver transplant, immunosuppressive therapy, developed pneumonia, bilateral pneumonia, he's on empirical vancomycin, cefepime, and oseltamivir, Tamiflu. Bronchoscopy was done, and the gram stain is showing gram-positive cocci and many white blood cells. PCR testing was done, and it showed positive Staph aureus with positive MEC-A, and it's the concentration or the copies are 10 to the 7th, and Haemophilus influenza 10 to the 4th. But the culture from the bowel is negative. What's next? At this point, if patient is improving, I don't have to go the whole 7 days or 10 days to treat the Haemophilus influenza. I need 2 minutes or 1 minute. We can go by treating only Staph aureus and see how the patient is doing, okay? I need just one more slide, please. You don't want to? Okay. So PCR helps with the following. It does not always means you have to escalate your antibiotic. In most studies, as you can see, when you do PCR, you de-escalate. Doesn't mean we give more potent or prospective antibiotic. The opposite happens. We de-escalate. For example, this study, again, most likely after doing the molecular testing for pneumonia, we de-escalate. Another test here. All of them says de-escalation is the most common results of doing the testing. I'll skip this because the same thing. And let's skip this. And finally, okay, sorry. So what you need to know that if you treat with confidence. Someone is sick, don't wait and say, well, I don't have cultures. You have an option to do molecular testing for the sputum. It will tell you something that maybe the normal culture did not show. For example, atypical pathogens. And sometimes just a simple coverage for atypical pathogens like Legionella can save lives. Thank you very much.